So my name is Sarah Milligan. I'm with the Oklahoma Oral History Research Program at the Oklahoma State University Library. Today's date is, I'm going to remember this wrong, it's March 7th. 7th. 7th? 8th? March 8th. March 7th or 8th?
Oh, March 8th. Yeah.
March 8th.
March 8th. Sorry.
No, between the two of us, we'll get it. 2022. We will be talking today about experiences in Oklahoma related to the COVID-19 pandemic. And part of this project is funded through the Institute for Museum and Library Services, American Rescue Plan grant funds. So that's it. At this point, you can just introduce yourself and then just say a little bit about yourself.
Okay. My name's Karen Allen, and I am a critical care physician. I work at St. Anthony Hospital in Oklahoma City, which is where I've been throughout the pandemic.
Okay. So are you originally from Oklahoma?
I am originally from Oklahoma. I didn't actually grow up here, but I've lived here since I went to college in 1988 is when I started college.
Okay. If we need to pause it at any time, we can do that too. It's not a big deal.
We'll see if they stop. If not,
that's okay. And we have visiting dogs today, so it's always helpful whenever someone doesn't see what's going on.
Yeah.
Oh, it's fine.
Visiting puppies.
Okay, so talk a little bit about maybe what you do as in critical care at St. Anthony's.
So I'm inpatient only. So
okay.
The ICU is staffed with 2 patients every day, or 2 physicians every day, and all we do is inpatient when patients come in and need to be admitted or taken care of in the ICU, and we're solely in the ICU, so we don't see patients in other parts of the hospital. So if they're just on the hospital floor, and there's 2 of us there every day, and then there's 1 at night, so it's 24-hour coverage of a physician in the ICU, and that's just because critically ill patients need a lot more care and a lot more physician attention, and so that's been a trend throughout the Oklahoma area as well as other states, just to have that physician in-house. So I work 15 days a month, and there are 12-hour shifts that we do either day or night, and then off the rest of the time.
Yeah. So how long have you been doing that?
So I finished my critical care pulmonary fellowship in 2013, and I worked for the university for several years, and I've been at St. Anthony's now for 3 or 4 years.
Okay.
For several years doing that in the ICU.
Okay. And what were you doing before you worked with the ICU? Were you in other parts of healthcare?
No, when I worked at the university, I did the ICU, but I also did pulmonary outpatient. So I had an outpatient practice as well as in the ICU, and kind of split time between the 2.
Oh, okay. Yeah. And so the pulmonary side of that has probably been pretty specific in the last couple of years too.
Yeah, for pulmonary as well. Yeah. Okay. Pulmonary, I don't do outpatient pulmonary, but I know several of my colleagues do, and they've seen a lot of follow-up COVID. So they kind of see patients after they have the prolonged admission and have been, in several hospitals. They'll see, because a lot of patients have significant lung disease following their long admission.
Okay. So I wanted to start with a little bit, and sometimes it's actually, I find it's a little hard to actually remember back, but I wanted to sort of to talk back at sort of the early days of the pandemic. And just like, what do you remember about like the sort of like build up, like, like the early days when we knew it was maybe something a little bit different, but not quite sure that.
So when we, when it first hit and everything shut down in March of 2020, we really were expecting to have this massive influx of patients into the hospital, and they tried to clear everybody out and canceled surgeries, and we were bracing for this major storm that we thought was coming. We'd seen what was happening in New York and the overflow and everything there, and we thought that was going to be us. And it wasn't. We actually weren't busy at all with everything shutting down, and I think it just took longer for COVID to spread in Oklahoma because we're a much more rural state compared to like New York City, where people are much more closer together. It just didn't happen that way, so we actually weren't busy at all. Some of our worst waves and things came later. But early on, I remember, we didn't have a test at that point. And so anybody who came in the hospital with any kind of shortness of breath, automatically we assumed they had COVID. And we would have to isolate them and treat them as if they had COVID, look for if they didn't have COVID. And at that point, it was taking our test 5 to 7 days to come back. It was taking a long time. So we had all these people, sort of in a COVID ward, but probably 90% of them at that point didn't have COVID.
Oh,
they were just admitted with other things. So we really spent a lot of time sort of, I guess, chasing our tail to a certain extent because of that. And we weren't as busy. It just never got as busy. And as a medical person, it was kind of like, well, wait, what's we were like expecting all of this, and it didn't happen. And we just didn't know as much about it. So most of the physicians in the ICU and most of the physicians in the hospital, everybody admitted that they were a little nervous about going to work. Like it was a little intimidating and kind of scary to be treating something that you didn't really know how to treat, and we knew a little bit about how it spread, but not near as much as we know now. And so you like, am I going to get it? How sick am I going to get if I get it? What's going to happen to me? It was very worrisome. And then a lot of people I talked to, and myself included, said it was the first time, was nervous or a little fearful coming to work about what was going to happen and what I might take home or bring to my family or something.
Do you remember when the hospital was trying to plan for that? Do you remember the process for making some of those decisions, or how that was communicated to you? Bracing yourself because you're seeing what's happening, right? Do you remember, how those decisions were being made to try and discourage non-essential care, or to try and make space for that?
All the hospitals in Oklahoma City canceled elective surgeries. So anything elective was canceled. And, we had this huge tent outside our ER ready for this mass influx of patients that we weren't going to be able to handle. But we actually never used that tent. It just sat outside the ER for a month. Everybody would look out the window at it. And nothing ever really materialized. But the hospital had a hard time obtaining, even though we weren't using a ton, they had a hard time obtaining protective equipment and, the eye goggles, the gown that you wear, everything like that. And I guess I say we weren't using it, but we were, because we had all these people we thought might have COVID who didn't. But it still wasn't a massive influx like, how you see on the news, people were sleeping in the halls and that kind of thing. We didn't have it. Everybody fit in the hospital, and we didn't have to use any emergency measures at that point as far as the patient capacity. It was later in the pandemic that we started to see the waves here in Oklahoma, where we got very full, where we turned people away, and had a lot more of a health crisis in the state. It was later in the pandemic.
Right. Right. And I will definitely get to that, because I think those waves of it are also just, that's what this whole thing's been about. But thinking through your comment about, you and maybe colleagues more than anything having those discussions about just not knowing, right, what you're bringing home, or what the impact is going to be outside of yourself. Are there things that you did or that you remember talking with your colleagues about doing to try and mitigate for that, or to try and I know some people, maybe if they worked at a grocery store, they would sort of strip outside the door.
Yeah, a lot of people did that. We changed sort of right when you got home, took a shower right when you got home. Hair covering became universal for everybody throughout the hospital. Usually it's only people in surgery that are wearing a head cover, and pretty much everybody in the hospital just went to wearing one. So you just didn't get anything in your hair. A lot of people would come to work and then change into scrubs at work and change out of the scrubs before leaving the hospital. The hospital provided just this huge thing of scrubs right outside the bathroom, right outside the COVID unit that we had converted over in the hospital, so that people could change and not wear their own clothes, just wear the hospital scrubs in the hospital. Everybody wore shoe covers. We just covered everything we could possibly cover with eye gear and everything. and it's so funny comparing that to later in the pandemic, where now we're all a little bit more, we still have the universal precautions for those patients in gown and glove and mask and everything, but we're all much more relaxed about it.
Yeah.
Several people, I also bought some kind of mask over the internet that was like what you would see painters use, or people who work with hazardous chemicals. Lots of people bought those, and some people couldn't find them, so early in the pandemic, if you ordered it early, which we had one actually that I was like, oh, I'll take that to work. But then I had some friends that were looking for one, and kind of desperately looking and calling in favors to sort of local supply companies saying, I'm a physician, I'm a nurse, I'm working with COVID, to make sure they could get one, as opposed to, trying to, because everybody wanted one. It wasn't just people in healthcare. So people had a hard time finding, a good mask. And so a lot of people had those kind of face masks because we weren't sure. We always had enough N95s in our hospital, but we were never sure. We were always worried about, well, what's going to happen? And we also worried about, well, what's going to happen if things really do get worse? Like they never did, but what happens if they do? Yeah. So a lot of people bought some kind of mask that was used and brought that to the hospital with them.
Mm-hmm. Yeah, there was the sort of general public statement of don't go out and buy masks because healthcare workers need them. Right. And there was sort of the later message of
buy a mask,
go
get a mask. Yeah. Mm-hmm. You need to wear a mask. Yeah. Mm-hmm. So a lot of people had bought some kind of mask for themselves, and most of the ones we bought were ones you would reuse, you wash and reuse.
Mm-hmm. So thinking about that setup, and it sounds like what you're saying too is part of the reason why maybe that initial sort of hospital spike didn't realize was because of, a lot of the public service or sort of public spaces shut down that happened early on.
I think we'll never know how much of a favor that may or may not have done for us. For economically, it was really bad and people were clearly upset about it. But I don't think we'll ever really know. Maybe that really helped us. It could be possible that we just weren't going to spread COVID as fast as bigger cities like New York did. But that shutdown may have also helped slow the spread and may have helped us. And it's hard to measure because how do you measure something that didn't happen?
Right.
Right. So and I think it's hard for people to see.
Yeah. Yeah. So that was sort of like when you were gearing up to do it. Do you remember the first time you heard about like COVID, like either in the news or was it?
Yeah, I remember hearing about it in the news. I don't know that I remember the exact first time, but I remember talking about it before March of 2020 when it was still, we hadn't seen cases in the U.S. yet, or maybe we thought we were just seeing those first few cases out in Washington state, but we hadn't seen that many cases here. And I remember just sitting around our physician team room talking to some of the other physicians, and we're all just kind of like, ooh, that's coming. And you kind of want to sit there and say, no, it'll be like, SARS, and it won't really make it this far, or, it won't really come. But then we're like, oh, is it going to come? We're just kind of sitting there watching for this wave. And a lot of physicians that I knew canceled their spring break plans that March. They just weren't willing to travel because they said it's probably coming. And that's really kind of when we saw that initial first wave and everything shut down, was right around the spring break time. So a lot of people canceled their plans, just decided not to go anywhere, just from watching the news and everything. Like we didn't really predict it. But we were just like, that's coming. Yeah. What are we gonna do? Yeah.
So sort of thinking through how, then state policy sort of, or, I guess I wouldn't call it policy, but sort of, like the state communication down about limiting where you go or trying to restrict spaces really only happened through like early June, right? Like that was like a 2-month period of that. And so that's also when, more people publicly started being asked to wear masks, or, I think that was the within that that space. So I'm thinking about with the hospital, like one of the first times I remember putting on like a face mask was going into a hospital. And it just sort of being this surreal thing. Do you remember, like, is that something that you all had to work out from the hospital side, like when patients came or when the public started coming through your doors? And
so I think, a lot changed as far as the hospital visitor policy and things like that. When we first, in March of 2020, when we first started getting patients for probably, maybe about the first 6 months, I can't remember exactly how long we did this for, the hospital just didn't allow any visitors. And it didn't matter whether you had COVID or not, you could not come in the hospital. And that was really tough. That really took a toll on families and on healthcare workers as well. And I know the nursing homes and other healthcare facilities had similar policies. And so that was really, that was tough on people. And I think, especially as patients got sicker, we had a lot of patients come in from nursing homes. As we started to see more COVID early on, we had a lot of patients who came from a nursing home who had gotten it in the nursing home because they were in a communal setting. And the families then couldn't have seen them in the nursing home for 6 weeks or 8 weeks, and now they can't see them in the hospital. Of course, a lot of these elderly patients with COVID weren't going to survive, and so it was really hard on families. That was really tough. But we limited, nobody could come in the hospital for, I don't know if it was 6 months before the initial wave of that pandemic. We didn't allow any visitors. Subsequently, what we started to do is people could come in with a mask, but they had to be checked at the door. So we checked for fever, had questions about symptoms, and everybody had to wear a mask in the hospital. And most people, it's funny how people had so much issue with wearing a mask throughout the pandemic, but most people in the hospital, that was not an issue. If they kind of, I think, resolved themselves that I'm going to the hospital, I need to wear the mask and not, and eventually we opened it up to where the COVID patients couldn't have visitors, but the non-COVID patients could have 1 or 2 visitors stay with them throughout their stay. It was still fairly limited in that families had to appoint 1 or 2 people, and so not anybody and everybody could come up, but at least somebody could come up, and so patients had a support person or an advocate, and that helped a lot with a lot of families.
Well, and you reference this, but also the toll on healthcare workers being the ones that are the only, the only person that patients are seeing in that situation. I'm sure you have lots of things to say about that, especially from an ICU perspective in that critical care space.
It was really sad. It was really sad because we had patients die alone. We had patients say goodbye to their family members over a video chat, some kind of Zoom call or something. That was one of the hardest things with the pandemic, is that particularly when we didn't allow visitors, but even when we had visitors, the COVID patients didn't have visitors. So the patients we've been dealing with COVID throughout the whole time have not had any visitors. And patients with COVID are a little bit different from some ICU patients in that they are very aware of what's going on and very aware of how sick they are. A lot of ICU patients, and I never thought about it that much, have a little bit of what we would call encephalopathy, and so they're a little disorientated or a little out of it, you could say, not really clear exactly on what everything that's going on around them or how sick they are, or how they're getting sicker. They just don't have that kind of realization from this encephalopathy. But COVID patients always had a very clear mind for the most part. I'd say 99% of them. And so they could see, the increased amount of oxygen that they're requiring and the difficulty, they're having more difficulty breathing, and they're getting more and more different types of machines to help them breathe. And of course, later in the pandemic, everybody had seen on the news, there was so much on the news about it that patients and family members too, their medical vocabulary had been expanded by that point. And so when you talk to patients and family members about, well, they may need a mechanical ventilator, they knew exactly what you were talking about. And most people associated that with death. And so patients were very aware of what was happening to them. And so being alone with no family, knowing you're probably going to pass away, that was hard. And it was hard to watch. It was, and particularly so, like for our ICU nurses, we had a really high burnout rate, and most of a lot of our ICU nurses are now nursing in a different capacity, because they just, they would be the one taking care of the patient all day, and it was just really hard hard to do.
When would you say that you saw some of that burnout rate start to happen? Because, there's so many waves of this.
Yeah. It probably started, for us in March of 2020, we really didn't have that many patients. And what we did have and what we thought might be COVID, a lot of it wasn't.
Right.
So we really started to see some burnout, I would say late 2021, mid to late 2021. After we've had a couple of really significant waves of COVID. And once it became so political, that's when a lot of things changed for the nurses and for the physicians as well, honestly. It was really tough to, we got a lot of family members, by then the medical vocabulary had expanded. And that was actually nice initially in the pandemic because we could talk to people and explain, and they'd seen it on the news, so they knew what we were saying. So it was a little helpful, and people had a good grasp of how things were going along. But as we got further into the pandemic, and people started wanting certain treatments, there's a lot on the internet about treatments that aren't studied, that weren't proven. Some actually thought probably could be harmful. But families had an idea of what they wanted, and they wanted to drive that treatment, and so they would say, well, I want you to give them this drug. And if that drug's not been studied or not approved for COVID or has no mechanism to improve patients with COVID, we wouldn't give it. And then they would, there'd be this battle and this back and forth. And then you'd get, for a family member, you'd get maybe, they'd pick the most aggressive vocal person in the family, who would be the one to start calling and saying, I want this done. This is my family member. I want this done, and I'm going to tell you what I want. And it's a difficult position because you're trying to maintain a relationship, and although your physician relationships with the patient, you have some relationship with the family, particularly a family who can't come visit, who's got a very sick loved one, and they're demanding things that you're just like, I don't want to do. It's not helpful. It could be harmful, and there's just this demand and this irrational, well, I want it. The family's asking for it, and medicine doesn't work that way. I just want to be like, well, medicine doesn't work that way. It just doesn't. I can explain to you why it won't. Why we're not going to do it, and we can talk about it. But just because you tell me you want it, it's not. You're not ordering off of a menu and to pick and choose. But that was the attitude that we saw. That was like, well, the family wants it, so you should do it.
Was that coming from hospital people or the family? The families were doing that.
The families were doing that, yeah. The hospitals were actually very supportive. Our hospital was, and I think most of the ones in Oklahoma were very supportive and said, we're going to do what our physicians think is best for the patient. So we didn't get pushback from the hospital wanting to give medication or things, Yeah.
Well, and I think, part of that is also, like the just massive amount of like rumor and conspiracy and information sharing that has been a big part of what has happened with this pandemic. And so it doesn't matter what someone comes in to say, whether they're talking about, giving dewormer as the thing, or there's so many other things. What are some of the ways that you tried to like have that conversation with patients? Because I think that's a big thing, that healthcare providers are now responsible for trying to be like conspiracy debunkers, right? Like, how do you talk?
Yeah, no, it's a tough one. And honestly, it's gotten progressively stronger and stronger from families. So as we've gone through the pandemic, there's been more and more, whether it was Plaquenil, hydroxychloroquine, and then we went to some other cocktails, and then it ended up being ivermectin, the dewormer. It's gotten to be a stronger and stronger request. And so, as healthcare providers, there's been, and in talking to some of my colleagues, we've sat around and talked about it, there's a huge, I don't even know how to describe it, just a huge feeling of, well, if you don't want my help, go home. But they don't, of course they're not going to do that because they can't breathe, they need help, but there's this thought that, you've come to seek my expertise. This is it, and if you don't want it, and a lot of conversations, we sort of had to leave it like that because a lot of people, you could tell them, well, there's no studies to show that the horse dewormer works, and it works for parasites. COVID's a virus. There's really no medical logic why it might even work, and people just don't listen to that. A lot of people just didn't care. They read on the internet, somebody had said it worked, somebody had said it was good for you, that it helped, somebody said they took it and got cured, and you could try to explain, well, most people with COVID actually don't really get that sick. It's actually less than 1%. So they might have taken it and they just might not have gotten that sick. But that doesn't mean it was from the ivermectin. It just means they weren't going to get as sick because a lot of people don't end up in the hospital. And some people go to the hospital, but they don't end up in the ICU, So, and it just, a lot of times that conversation didn't end well. You left the conversation as well. This is how it is, and this is my medical decision. And we had a lot of people, we've definitely seen an increase in people saying, well, I want to transfer to another facility, to a physician who will provide the care that I want. And you say, okay, find a facility that will do that, and find a physician that will provide that care, and we'll be happy to arrange a transfer. Knowing that there's not going to be anybody that will provide, a horse dewormer for a virus, but you have to leave it like that, because what else are you going to do?
Yeah. I was going to ask, did anyone ever actually find a place to transfer?
Nobody that I know of, no. We would transfer patients. We transferred some patients we don't do ECMO at our hospital, and so we transferred some patients to ECMO centers, both in Tulsa and Oklahoma City, and I think we even sent a couple out of state.
What's ECMO?
So it's another level of care beyond a mechanical ventilator where they can oxygenate the blood without using the lungs. And so Baptist does that here. OU does it some. There's one hospital in Tulsa. So it's kind of subspecialized a bit, and it's not appropriate for all patients. It's a very limited resource. And so they would only take very young patients, patients who had a very good chance of survival, because they actually didn't have as good outcomes as they might normally have expected. So even the patients on ECMO didn't do as well as you might expect them to have done with COVID.
With COVID?
Mm-hmm. Yeah, if you think about COVID, when we intubate somebody in the ICU, if you take all comers, probably 70% can get extubated, depending on why they get intubated. Mm-hmm. But if we look at like respiratory distress syndrome, the mortality for that's 30%. So about everybody we intubate, we extubate somewhere around 75%. With COVID, when we intubate patients, the mortality is 90%. So we extubated about 10% of those patients. And that was nationwide. There's some published studies that it's about 10 to 12% is the survival. So if you came to the ICU and you were put on a ventilator, you were probably going to die. Mm-hmm. Mm-hmm. And that was really tough to tell families. And it was hard for them to accept too.
Yeah. Well, and that significantly changes your job as well.
Yeah. It made it a lot worse. The ICU, it's bad when the ICU physician says, I'm tired of seeing people die. Because we, as an adult ICU physician, we see a fair number of patients pass away in any given, week that I work. But a lot of the patients we see pass away have very end-stage cancer or have very end-stage liver disease or something that has contributed significantly to their death that's been kind of building over the last 6 months or something. These aren't people who were 2 weeks ago out living their life doing whatever they wanted to do, who would still be living their life had they not gotten this viral infection. Mm-hmm. And it was really hard to watch. And there was so much, it got really difficult once there was so much finger pointing. Before the vaccine, when people got sick, it was, well, did you wear a mask? And I would talk to people like when I left work, and I would just it's such a long day, and all these people are really sick and dying, and it's tough to well, did they wear a mask? They probably didn't wear their mask. And so I don't know. I mean, I got COVID. I wore a mask everywhere I went. I got COVID. You didn't have to be. You could be perfect with your mask and still have gotten COVID, particularly early on if you were wearing a cloth mask, which now we know aren't as good. But, and so there was a lot of finger pointing. And I think some of it was because things got so political. But I think some of it was also, well, they didn't wear a mask and I wear a mask, so that won't be me. When bad things happen and people get sick and die for poor reasons, I think we all feel this need to say that won't happen. That won't happen to me. Mm-hmm. I won't be that person.
Right. Situations
right.
where there's no control.
Right. Yeah. People don't like no control. And then once the vaccines came out, it was, well, did they get the vaccine? Were they vaccinated? And that was a little tougher one because that was a choice somebody actively made, and so that was kind of tough because most of what we saw in the ICU at that point was unvaccinated patients. That's mostly what we've seen since the vaccines came out.
Which has been about a year at this point since it's been sort of widely available.
Mm-hmm. And they've all been unvaccinated, a couple of vaccinated patients, but a lot of the vaccinated ones we saw in the ICU did actually recover. But it's hard to watch someone, when you think about all the misinformation that was out there and you think about so much of how the vaccine rolled out in the midst of the election. It's hard to think, when I talk to people like, well, they weren't vaccinated, it's like, but they didn't deserve to die just because they weren't vaccinated. And a lot of the unvaccinated people weren't staunch non-vaccinated. Some were staunch non-vaccinators. Others were like, well, I just wasn't ready, or I just wanted to get some more information. And okay, how much information did you really need? I think, but it wasn't. It was just people trying to make decisions and not thinking that this would happen to them.
Yeah.
Honestly.
Right. Well, and you mentioned that a lot of the vaccine rollout was happening in the middle of a really political
right.
space.
I think that if the vaccine had come before or after the election, that might have been helpful. It's hard to say. I don't know. It was so politicized anyway, but it just seemed like the rollout during the election, once Biden won and Trump lost, I think some people thought it was disloyal to Trump to go get the vaccine. And I don't know why you would think, it seems like an odd thought. I mean, he was vaccinated, but people certainly, I think, felt that way. Mm-hmm. That it was just kind of this, I'm not a true Trumpian Republican conservative if I get vaccinated. And some people got criticized. We talked to some families where the one individual, in the family would admit, well, I never told them that I got vaccinated, but I got vaccinated. The one member of the family was sick, and this other person would be like, I didn't want anybody to know, but I went ahead and got vaccinated. I'm like, okay. So we saw that too. Mm-hmm. Like some people didn't want to admit it to their family or friends, but they got vaccinated.
Yeah.
So it is just sad that people subsequently, that some people lost their life because of that.
Yeah. Well, and you think about that as part of this larger public health campaign and discussion. Mm-hmm. I mean, I don't know. I mean, in ICU, you're not necessarily talking to patients when they're doing preventative.
Yeah, we're past the public health point of it.
But still having those conversations peripherally as family comes in.
Yeah. And occasionally we'd have family that would come in or call. Most of this would be on the phone. And they'd be like, well, what do you think I should do? Should I get vaccinated? Yeah, I think you should get vaccinated. Particularly because we did see some COVID run-in families for whatever reason. We did see some families where lots of people within the family got sick. So if you've got a loved one that's in the ICU on a ventilator, you might be at a similar risk, and it could be that they had other risk factors. But the answer we always said was, yes, you should go. If this is going to tip you over to do it, do it. It's not too late.
Yeah.
Go ahead and do it.
Yeah. One question about that, sort of like just general information about COVID that was happening, specific to Oklahoma. Do you remember, or can you talk much about how the sort of state responded to what was happening with COVID and like there was regular briefings and there was,
So the state response, and this is just from my perspective, and I may have missed something, but the state response was really minimal. We would watch, sometimes they would have news conferences with the CMO of OU and the CMO from our hospital and from Baptist, and we would watch those, but we as physicians didn't get extra information or extra material or anything else, and maybe that some of that was communicated to the chief medical officers. I feel like our hospital would have trickled that down. They tend to do fairly well with that, but maybe not. So some of it might have been communicated there, but there was no cohesive response of the state as far as what to do. And in trying to, would we be looking at, and they'd be talking about, well, there's this wave coming up. We'd be trying to figure out where we're at in Oklahoma, like how are we doing from a state perspective? What's our positivity rate? Because that always gave us some information as to how busy are we going to be in the next couple of weeks. It took, once the rates would go up, it would take 2 or 3 weeks before patients to get sick enough to really need the ICU. So we would kind of watch those numbers a little bit for curiosity and also just to kind of judge. And the state numbers were very poor. They lagged. I don't think the reporting was very good. I don't think the tracking was very good. We stopped watching the state website, and most of us, we would look to the CDC, which that was impacted by state reporting as well. But we could kind of look and see what was going on around Oklahoma to get a little bit of an insight, although that's never was really exactly the same because you can see variation from county to county. But the state numbers were not, I feel like we didn't get any support from the state. And I think actually, I found out sort of after the biggest waves of the pandemic, I think people actually passed away and died because the state's response was so poor. I was talking to some of the physicians who work in the rural areas, and so, all the hospitals in the city would not accept more patients than they could care for. So if we didn't have a bed, we wouldn't accept a patient from a rural hospital or a rural facility. And that was true for all the hospitals in the city. And some of it has to do with whether the state's issued an emergency order, because that protects the nurses a little bit if they're over their number of patients, and it helps protect people if you're sort of stretched to a limit to where your care starts to be compromised if you get stretched too much. And so the state would never declare this state of emergency or anything. And so hospitals really, if we had a bed, we took a patient. But if we didn't have a bed, the patient would have to wait in the rural facility. And the rural facilities, though, they're not equipped to handle critically ill patients. And so I was talking to a physician who works in one of the rural hospitals, and she was telling me that they had 5 patients with COVID, all on ventilators, in their surgical PACU area, which is sort of the post-surgical care unit. And for some hospitals, if you don't have an ICU, that's probably outside your ear, or the place to put up the sickest patient is the surgical PACU unit. So they had 5 patients in this surgical post-care area. 3 of them were on a monitor. So 3 of them were on a cardiac monitor, a respiratory monitor, a standard monitor that an ICU patient's on, a blood pressure monitor that's timed every 5 minutes, however often you want to time it. 3 of them were on a monitor because they only had 3 monitors. And so you sit there and you're in shock about, wait a minute, how do you have 5 patients on a ventilator? There's no ICU nurse, there's no ICU physician. In some hospitals, it was just a nurse practitioner, and I'm not saying anything negative against a nurse practitioner, but that's not the practitioner who should be taking care of 5 critically ill patients on ventilators. And they just didn't have a place to go.
Do you think that would have changed if there was like a state of emergency or some sort of state?
I think so. And it might be, it's just too pie in the sky to think that it did, maybe, but I think so, because I think as physicians, we honestly look to take care of our patients and take care of the state, and so if the state had said, these patients need a critical care doctor, will somebody please go? I don't think somebody would have gone all the time, but somebody would have gone to help set things up, to help, this is the main things to look for, rotated there. I think we could have tried to trade some patients that were less sick with some of these hospitals to coordinate where some other patients could go. Excuse me, sorry.
Okay.
To try to trade off and say, okay, if they're not as sick in the ICU or they don't need a ventilator, they don't need a dialysis machine, they can go to a facility outside the city. And I think it would have been a massive coordinating effort. And I don't know any state that did it, honestly. But I don't know that it's impossible had we really put an effort into it. But there just wasn't a lot of coordination. The hospitals, I think, in the city were very coordinated in trying to send out a message of, we don't have ICU beds, please take care of yourselves, don't come to the ER unless you really need to, and some messaging to the public. But we left the rural hospitals to stand on their own. We didn't help them.
Well, and I wonder how some of that also played into, like you said, the numbers were kind of, like you tried to watch the numbers from the state reporting side and that wasn't clear. So part of that is there wasn't a clear understanding of what was happening in other spaces until reflective, right?
Yeah.
But as far as that went, hospitals were required to report numbers into a system. Yeah. Do you have any idea of how that went from the hospital's perspective in trying to divvy out COVID from non-COVID reporting systems?
No, our infectious disease nurses did that. Okay. And I didn't hear that as far as reporting, they didn't seem to have any problems. They didn't discuss any problems or anything like that. And there was some websites set up where you could look and see on positivity for cases. So we could look at tests at other places to see if someone had tested positive in a different facility or an outside testing facility or something. Yeah. So there was some of that set up to help support and kind of from that standpoint.
I think I had read somewhere part of with even those numbers was that even some hospitals were still having to fax results in, and a lot of them still these analog spaces instead of being able to do those numbers. So part of what the state's response is that information, but also what you sort of referenced with just people getting their own information places, right? So I'm just curious, did you watch the news more broadly? Did you watch Oklahoma national news to see what was happening, and what where were you getting that information from?
Most of my news I get from I watch CNN and MSNBC, so most of my news came from one of those sources.
Yeah.
I watched the Oklahoma local news some, but not as much.
Yeah. Was that something that came up with patients when you would sort of have these discussions about what they wanted, as they got increasingly more opinionated about treatment? Was those information sources one of the things
I think a lot of stuff was coming off the internet in talking to patients. I think a lot of the stuff they were seeing was coming off the internet or what they heard from someone else. And it was out there. I had a lot of patients at one point. I was at work one week, and a lot of patients were telling me they didn't want remdesivir, which is one of the antivirals that we used, whether it worked or not. On the ICU patients, it wasn't as effective because I think they were just at a point where it just wasn't as effective. But I had a lot of patients all of a sudden say they didn't want it. And it's, when someone's calling out a drug by name, you're like, what's up? Somebody's, and so I just Googled it. And sure enough, there'd been, and it was a legitimate report that some glass had been found in some of the vials. But those, of course, had been recalled. And, the drug we had was safe. And but because that had been found and reported, I think it had made it to other websites to say that this is, they're trying to harm you or this is harmful. Don't let them give this to you. But I had to go out and Google it. But it took me 5 minutes to figure out why all these people didn't want remdesivir anymore from the internet. It's like, oh, well, that's why.
It's a very specific instance, right?
Because I'm like, these people know this drug name. Because it wasn't one of the ones that had ever really been that much in the news. And all of a sudden, everybody knew that drug name. I'm like, something's up. And sure enough.
It's like, so if someone can repeat the same thing every time they walk in, then there's definitely something going around. Yeah.
And it was 3 or 4 families well, we don't want them to get the remdesivir. Okay.
Interesting.
Yeah.
There's also the things with healthcare workers in general. Well, sort of was sort of seen as like first responders for any of those spaces, or essential workers, right? These big campaigns, sometimes driven by hospitals and a lot of times by communities, to like, you know, have this like our heroes in our communities and sort of. And I'm curious, like, how did that make you feel, and your colleagues?
So, I mean, you know, at the beginning of the pandemic, I'm glad you mentioned this. This was one of the things I was thinking about. At the beginning of the pandemic, it was really nice. It was really heartwarming, and it felt really good. And especially because we really didn't know what we were up against. And we're all coming to work, and we're all a little nervous about it. And so it was really nice. It really was. We got food from places. We had cards, and a lot of family members, you know, we had some that were very demanding, but a lot of them said the opposite. You know, I have to give credit to a lot of family members were very thankful and could be very, you know, nice and very thankful to us. That dwindled as the pandemic went on, you know, as we all got more used to, I guess, sort of COVID and living with COVID, and this is how things are. That kind of support and that outpouring dwindled some. And so what took over, and I guess is what's more in my memory now because it's more recent, is just, you know, people saying, well, you take care of the people you want to take care of, and you only treat the people who, you know, you want to treat. Right? You're holding back because you get paid more, or something to that extent. And so that did unfortunately dwindle, and I think some people just got used to COVID, and so it wasn't, you know, and then we see more of just conspiracy theories of you're holding the treatment back, you get paid more if you treat COVID, so that's why you're coding it as COVID. But we had some people, you could tell me that they had COVID and they would say, no, I don't. Up until the minute you intubate them and put them on a vent, I don't have COVID. You know, and funny, you get to a point where you're like, well, you're sick. So, I mean, you know, and that sounds so flippant, but it's like, well, you know, you're still sick. Whether you want to admit why it is or not, okay, but you're still sick.
Yeah.
We're still going to have to treat you. Okay. You know, so we had some people just deny completely that that's what they had. And people say, well, you know, you're just doing this because, you know, you paid more or for whatever reason, or you hold back. I mean, and that was tough to take because it's like, okay, not only am I coming to work every day and taking care of unvaccinated people who could have not gotten sick, but now you're telling me that I'm not treating you, you know, to the best of my ability. You don't know anything about me. You don't know why I'm a physician. You don't know what I look forward to, or what I like about being a physician, or why I chose critical care. And you're really you don't know anything about me, and you're telling me that I would do that? I mean, I don't know any physician that would do that. Mm-hmm. You know, I mean, we're not all critical care. We all have different specialties, but I think they would all take care of someone to the best of their abilities, you know. I think everyone in the pandemic did.
Yeah. Well, I think that's an interesting thing too, about like thinking about the beginning and sort of where we're at now, like the public response, as well as sort of community, sort of like we're all in this together, right? Right. Whereas sort of this fatigue now
there's a lot of fatigue now
settled in,
and it's back to, well, you did something wrong if you have COVID. Mm-hmm. You know. Mm-hmm.
So in these middle spaces where we have these surges, so like you framed at the beginning, like everyone was really prepared and braced, and like that wave never came, but also said like there were
we did see waves. We did certainly see waves.
So yeah, when did those sort of take place, and like how did that
we saw? I forget when our waves kind of came and went, but I think
the first big one was like fall 2020.
Yeah. We saw a wave then, and then I think we saw some after Christmas in 2021. Then we had some for spring, spring, anytime there was a major holiday or something, we would see once fall of 2020 hit, and we saw anytime there was any kind of holiday or kids out of school kind of thing, we would see a bit of a bump, Yeah. Like we saw for Thanksgiving and Christmas, we saw some bumps in 2021, early 2021. We saw a fair bit last summer in 2021. And what we saw was parents who got sick after their kids went to camp. So their kids went to camp and got COVID and came home with COVID. And then the whole family would get sick. And one parent would end up in the hospital, usually, of the ones we saw. And we had some parents pass away after their kids. And you sit there and you think, that's really sad, because that child, a lot of them were old enough to figure out where dad got COVID, or how dad got COVID. And that's, I wonder how that's going to affect them. And that's really sad.
Yeah.
I know when I got COVID, I admit I went over to my sister's house. I think we kind of opened up our family circle, and she was in my circle. And so I went over to her house. I was there 10 minutes without a mask on, and I gave her COVID. And that to me was scarier than having it myself, because it was like, if anything happens, we're twins. And so I was like, if anything happens to her because I gave her COVID, I mean, I don't think I could live with it. I mean, that would be, so once I was worried when I got it, I was like, oh, what's going to happen? And then when she told me she had it, and I knew she got it from me, and I was, that was then my fear was like, well, what, is she going to be okay? It's not, when am I going to be okay? So these, families who got it from a family member, that's tough. Yeah. And we had some kids in camp that got, the family all got COVID. And so anytime there was any kind of increase in social activities, we would see a little bit of an increase. We always had this sort of continuous, we always had a certain number, but we would see bumps.
So do you remember like the first big wave, which I do think was like that fall 2020, not necessarily correlating with like back to school, but not, I'm leading up into probably closer to Thanksgiving, like that.
Yeah.
Like, do you remember, like, was there you and your colleagues sort of like discussing, like that feeling like it was an increase, right? Like I think once that wave hit, from other people I've talked to that have worked in hospital settings, it was just sort of this like exhaustion, right? Like the exhaustion finally caught up.
It was, right? it did. And that's kind of what we expected in March of 2020, which we never got. But yeah, in the fall when we saw our first wave and we opened our COVID unit, so we had a full ICU open dedicated just to COVID. It was exhausting because the patients were hard to take care of. They, it's some of the most stressful patients, taking care of these patients. Partly because you would talk to them and they knew what was coming. By the time they were in the ICU, it was really emotionally tough for the patients. They were isolated, they were alone, their food everything came in a paper cup that got thrown away. The doors were kept shut to their room. People had to gown up, and so everybody went in when they needed to provide care, but nobody went in just to say, what can I do for you? Or, those kind of small gestures. And I say nobody did, that's not true, but it wasn't as much as it would have been for a patient who otherwise was not in that situation. So it was really tough caring for these patients, and they, of course, knew how sick they were. They could see themselves getting sicker. And it was really, it was exhausting. Yeah. It was hard to even going in that unit. We've always had the same unit that we've closed throughout the waves. We've had the same ICU that we've closed to be our COVID unit. And going in it is just the most depressing thing. And the last time we had to open it up a couple of months ago, several of our nurses were just in tears because they just didn't want to go down there. They didn't want to be in that situation again. It's so sad. Like I had one patient who was, I think, in one of the very first waves. He was probably my age, a little older, had diabetes, but not an unhealthy person otherwise. And he kept saying, "Well, I went to my granddaughter's birthday party." He's like, "I shouldn't have gone." He's like, "That's where I got it. My wife got it. She was at Mercy, but she was getting better, and he was getting worse in our ICU." He's like, "I just shouldn't have gone, but I just wanted to go to my granddaughter's birthday party." And it's like, well, you really shouldn't die because you went to a birthday party. I mean, it's terrible that someone has to let that happen to them. because if you think about your life and you think about how you lived during COVID, nobody was perfect. Nobody masked 100% of the time. Nobody never did anything they weren't supposed to do, but for the most of us, that was okay. But for some people, it wasn't. And so to me, that was really sad to see these patients, sit there and think about regret, and think about what's going to happen. And they had some idea, and most of them passed away. We would have families, because the families were not allowed to come in, but the ICU beds all have windows, the rooms all have windows outside to the street. And so we had a lot of families that would come up on the weekends with, friends, or, there'd be 10 or 12 people waving and holding up signs to patients. And so we would try to get the patient over to see out the window, which was not a simple thing because the oxygen, is attached to the wall, and the windows over there, you've got to get it all to stretch to get, and so that was something the nurses did a lot to try to figure out how to, and some of these patients, they couldn't really get up because when they got up, their oxygen would drop. And so try to how to get the patient to where they can see out the window so they can see their family. Yeah. That was really tough.
I've never thought about the actual logistics of getting someone to the window at those instances.
Yeah.
So
you kind of really catty corner things and try to, so that they could see their families.
Which, and even this idea of throughout the entire point of COVID, if someone is in an ICU unit with COVID, sometimes the only way that they are able to communicate is through a video phone chat or something like that. And, I think nurses and other medical folks that are there are the ones that are helping facilitate that. So not only are you trying to care for this, these
right, but now you're trying to
now you're trying to figure out how
to it takes a lot of extra nursing care, I think, to take care of the COVID patients, because of you're trying to schedule these calls and perform the call, and patients are often very short of breath, and so it can be a little bit tough to be on the call because talking would make them short of breath, because it's that's how sick they would be. And so then after the call, the nurse would really need to get them to calm down and rest and take, and try to get their oxygen to be better, to have. So it was really, I think, and that's kind of partly why it's just so exhausting, because there's so many other little extra things that you're having to do. And in patients who otherwise are just sitting there watching TV, they would not be sick in any other way, but they would need a lot of extra oxygen and very high oxygen on certain devices that could provide this. And when they would move to try to even just go to a bedside commode, their oxygen saturation drops. And so then you got to get them back in bed. But otherwise, the patients are just sitting there. They don't really feel bad. Otherwise, they don't have any other organ failures. They're not otherwise sick. By that point, usually patients aren't having a lot of fever or other symptoms. Those have kind of subsided, and they're just waiting for their oxygen saturation to get better, to leave, or to get worse and get intubated.
Were some of those ways that nurses were having to do extra, like the figuring out how to communicate with people who weren't there and all those, were those things that the hospital was doing before COVID, or is that something that really...
No, that started mostly with COVID. Before, we'd always have family members with updates over the phone, but because families could come up to the ICU, and visitor policies in most ICUs is fairly liberal now. Family members are able to stay throughout the day. We would just do bedside updates as the family was there, right, and just do phone if they couldn't come or whatever, if the family was working or couldn't make it that day. So a lot of that was just with COVID. Once we stopped allowing the family to come in, we had to figure out other ways to communicate with them. And a lot of families, they did Zoom calls. We would call the families, the nurses would call and talk to the families over the phone. A lot of families would bring things for their loved one up to the hospital and just give it to the person who was watching the door to train, would bring it up to the ICU so they could bring things for their family members, but they couldn't come in.
So did you all have the equipment to do like video calls, or would you do that on your cell phones, or did the hospital buy iPads?
The hospital did eventually get some iPads. Initially, that the nurses were using their cell phones to do it. Or the patient's cell phone. A lot of times we'd use the patient's cell phone if they had one. Their family would bring up the charger, and so we would just leave it charged in. And most times, patients who weren't too sick could do it on their own. But as patients got sicker, they would need the nurse's assistance more and more.
Yeah. Yeah, I wondered. I mean, the equipment thing is interesting because you think about, what more publicly gets in those spaces are like the PPE shortages, and then the waves of that being enough or not enough or whatever, but not all this other equipment.
You need an iPad, and it changed that ICU significantly in the sense that family members would bring things for the patients, and sometimes we did have one patient who passed away that a friend, he actually didn't have much family, but a friend had brought, he liked to listen to records of like big band era and musicals. And so he brought this record player that was the patient's, and we put it in his room, and even when he was intubated on the vent, we would play the record player in his room, and he left that for the hospital. And so we had that at our nurses station, that when things kind of got stressful and everybody, we would play some records. And so some of the physicians, I actually bought some records from Amazon to kind of add to the collection, because his music was a little bit older taste than what most of our nurses listen to. So I bought Grease, something a little bit more. So we would play the records at the nurses station, something kind of, soothing while you'd be charting or something, as opposed to, just day in, day out, because it's a day in, day out kind of grind.
Well, and that along the lines of like what you all did to try and just support each other in that situation, especially in those big waves of just intensity. Was there mental health services provided, or counseling spaces, or debriefing spaces, or anything like that? Yeah,
the hospital had a campaign that did a mental health, sort of a wellness check that you'd go in on the computer and fill out, and to see if you were burnt out. I think they offered some counseling for the nurses. I'm not honestly sure, but I think they did offer some counseling. It wasn't easy to get, though. I know a lot of nurses who looked into counseling, and I asked a couple about it, even for myself, but the counselors were full. They got so booked up that even if you wanted to go, you were 6 months out of an appointment. And so there was that seemed to be the biggest barrier to that there's not a lot of counselors in the state. They're kind of, I think, had busy practices before the pandemic. We weren't the only people with grief and problems during the pandemic. So the, access was a barrier if you wanted some counseling. I know a couple of the nurses were telling me they waited 6 months or so to get an appointment. But just felt like they had to at least make that appointment, and when it got here, see if they still needed it. Because it was really tough, and a lot of them changed. Like I said, a lot of them changed jobs. Just said they got tired of doing it.
So did you see a lot of new nurses come in training during this time too then? If there was a lot of turnover?
We did see a fair number of new nurses. We saw a lot of, and all the hospitals experienced this, we saw a lot of contract nurses because we would be so short of nurses that we had contractors coming in. And some of our nurses left to be contractors because they could get paid so much more. And so you can't really blame them. I think the hospital did a pretty good job of keeping our nurses for the first wave or so. But after that, the contracts were paying 3 to 4 times their salary. Who's going to say no? If you can travel, who's going to say no to that? And so a lot of our nurses did go take contract jobs at other places. And then we had contract nurses coming in, and that's hard because you don't know them as well. They don't know you. Some of them stayed long enough that we did get to know them, but it's a lot easier as a physician, and I think as a nurse too, to work with someone they know what they can call and tell me, and what I'll and I think a contract person is just hard. You don't know the physicians, you don't know how the hospital operates, the normal kind of flow of things. So I think that's kind of difficult. It made things a little bit more difficult. And I know other hospitals experience that quite a bit with contract. At some hospitals, the majority of their nurses ended up being contract nurses. Because it was just kind of, everybody wanted, if you're going to have to deal with the pandemic, why shouldn't I get paid?
Yeah.
I mean, it's hard to blame them.
Yeah.
Because the nurses, I think, had the worst job, is that they were at the bedside all the time, seeing the patients and taking care of patients. Before patients went on the ventilator in the ICU, there's a lot of an emotional toll. Nurses, you get to know the person, you're the only person they talk to. And then once they went on a ventilator, there's a lot of heavy lifting, and because we prone patients, and so you're putting patients on their stomach, and so there's a lot that goes into that, care-wise. So they weren't easy patients to take care of.
Yeah. Well, what about physicians? I mean, you mentioned that there was physician burnout too. Like, what did you see there?
So nobody quit. We kind of sucked it up. Nobody quit, not in our ICU anyway. I think we all worked together to a certain extent and talked together about it. After that vaccine came out, people had access to the vaccine, and we were still seeing. I mean, we had some of our worst waves, 6 months after the vaccine been out, and so that was really tough. And I know, in talking to some of the other physicians, we all sat there and said, I'm trying to have empathy. I'm really trying to have empathy. But it's tough, and particularly when then the family tells you how they want you to take care of them, and it's really it really got tough to have empathy, to tolerate this constantly being told what to do. It got really tough.
Yeah.
I can't think of anything specific that anyone did or that I did, other than just venting to each other, venting to my family about it. I did think about, I think if the pandemic was going to go on another 2 years, as bad as it was at its worst, I would find another avenue of medicine to practice in. We've seen sort of a light at the end of the tunnel for the last month or two, that we're all very, very happy, and knock on wood, that we're all very, very happy about. And so we're hopeful, because in the sort of the darkest days of those waves, when the COVID ICU would be full, and you're taking care of the patients, and you've got upset families, you've got patients telling you they don't have COVID. It's a lot to sort of deal with, and some of these patients are the most stressful patients I've ever taken care of. We would wait to put them on a ventilator, and so in doing that, they become a very high risk intubation. And out of OR, intubation has about a 10% mortality rate with it. And so it can be stressful depending on what else is going on anyway. But some of these patients, when we would intubate them, and so that's when we'd put the tube in that's going to connect them to the ventilator, so the tube's in their trachea, in their airway, their oxygen saturation would drop into the 50s, into the 40s, because you start in the mid 80s, and then you've got to take the oxygen off a little bit. We would leave some of it on through the nose, but you've got to have access to the mouth, so you can't have a mask on. And it would drop into the 50s, and you'd hook them up to the ventilator and just stand there and you'd be like, please come up, please come up, please come up. Because you don't really have much else that you can do. We can do you can try some breathing treatments and some things that might help. There's an inhaled medication that helps with oxygenation a little bit, but there's not a lot you can do, and you just kind of sit there and eye on the monitor, please come on. And so it's very stressful, especially when you're talking about a 20-year-old or, a 30-year-old, and you're like, this person might just die in front of me, and at that point, you can do CPR and you can do cardiopulmonary resuscitation, but it's not going to be effective if you can't get their oxygen above 50. It's not going to be effective. And so it was very stressful. Some of those intubations were some of the most stressful, and we would we would, between the day people and the night people, we would joke, like, if they're probably going to need to be intubated on your watch, and then if they didn't, they'd be like, nope, they made it, they're your, because they were stressful. Like, none of us really wanted to be the one that had to ultimately go in there and say, okay, now's the time, because you could see as they required more oxygen and their oxygen saturation would drop with more oxygen, you could kind of see it coming. You could tell that at some point they're going to need to be intubated. But when exactly is the right time, it's hard to say. But you could tell that they would need to be at some point. So you'd watch and you just kind of wait. Is today the day? Is today the day? Knowing that it was just going to be this awful, stressful event. But, we had some patients that didn't survive the intubation just because their oxygen dropped so low. Mm-hmm. Their heart stopped, and they didn't survive the intubation. That was rare, but it did happen.
Yeah.
So.
Well, and with a 10% survival rate.
And once you do that, you've kind of set their course anyway. Mm-hmm. 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 And then it's just a matter of wait and see of time, And certainly the ones we did see survive were younger. We had a 50-year-old, 52, who survived. And we had a 40-year-old that got really sick and survived. We had a 21-year-old who got really sick and she survived. But 60, 70, it was really close to 100%.
Yeah.
Yeah.
Well, and when you were talking about, people just like wanting to find a reason why it's not going to be them, right? But I think that's part of it, is like there's no predictability. A 20-year-old and a 40-year-old, a 50-year-old, a 70-year-old. It's just, there's nothing you can point to say, this is it. This is it. All these things triangulate to, you're going to be the one in the ICU, right? Mm-hmm. Mm-hmm. Well, in thinking about this, and I know a lot of people are reflecting and will continue to reflect, is there something that even from the hospital side of things, that either looking at how things were messaged, or, if there's things that we could do differently to have, you can't change the health side of it, you can't change the contagion part of it, but as far as even, as thinking of it as this pandemic, are the things that we would hope that would be done differently, or that looking back we wish would have been done differently?
That's a tough one.
I know there's no magic answer to that either, but
I think the messaging becomes really important. And so much of the misinformation drove a lot of people. I think people sometimes deliberately did things that were, put them at bigger risk, at higher risk, because the messaging came from, they thought it was liberal messaging. So and I think people put themselves at risk. So the messaging becomes, I think, really the public health aspect of it. Once you land in the ICU, there was not much, like we've talked about, we don't do anything for these patients. We support them, and we provide oxygen, and we intubate them, and we put them on the ventilator. But at the end of the day, if you make it, you're going to make it. And if you're not, you're not. And there's very little that I, as a physician, do that's really expertise driven to help with that. Is how we all felt. We can do our best practices, and usually that really helps people. In the pandemic, maybe it did, maybe it didn't.
Right?
I don't know. And so it's the messaging, I think, and that's tough. I think if we saw another pandemic tomorrow of a different virus, we would see the same stages and the same fear and the same misinformation and all of that. I don't think we would see, at this point, I don't think we'd see a change. I don't know how you message better and how you manage, with the internet. I don't know how you manage all the misinformation, Right. Maybe a pandemic 50 years ago would have gone a little better, before the internet, and before people had access to just so many sources of information and so many sources that aren't valid. But even then, I think you'd see that, just that fear reaction that people have. There's just this desire to say, I'm excluded, or I'm not gonna. That's not gonna happen to me. It won't be me that gets that. And that was the saddest thing. Looking back at the pandemic for me, is like I saw the people who did get caught in that, It was just, it's just the saddest thing.
Did you, with people knowing like what you do for a living, right? Did people ask you a lot?
All the time. All the time. People all the time wanted to know, well, what's it like in the ICU? And so you'd start telling people, and then they're like, oh, and then they don't really want to, some of them didn't really want to know anything else, because you start, my sister-in-law is funny, she'll laugh at me because she'll, we would go have dinner, and she'd be like, oh, I had a bad day, I had to deal with this and this and this, and she's like, oh, well, how was your, how's your week at work? And I'm like, oh, well, these people died, and this happened, and she's like, oh, okay, never mind. But yeah, a lot of people would want to be like, well, what's it really like? And it's hard to describe. It's hard to describe what it's really like, and just the emotional toll of seeing people who are just sort of sitting there waiting to see what happens to their oxygen saturation alone. It's hard to describe that emotional toll on the patient for sure, but then you also, it's hard to see this person in this position. And again, it got to where it bothered me when people would say, well, did they wear a mask or were they vaccinated? Because it's like, well, at this point, no person deserves to be sitting in an ICU alone thinking, am I going to die? It's just, it's sad, regardless of what they think or what they did or didn't do. Again, I think nobody's behavior was completely perfect to prevent themselves from getting COVID. So it's very hard to describe that emotional toll. And talking to the families, that took a toll as well, because when you call the families, this sounds so awful, and it's not, but I got to where I would, was talking to some of my colleagues, and I get on the phone and you tell them what's going on for the day or what's happened, and then you have this period where they cry. You just have to wait, and then you can go back to talking again. And that was every family. You tell them, they cry, and then we talk a little bit more. And it's just like, I got tired of listening to people cry on the phone. I understand why they were, and I'm sure they got tired of crying on the phone, and they didn't want to be in that position anymore than anybody else did. But that was really hard. And for some families, once you got to know the patients a little bit, or if I saw any kind of familiarity between that patient and my family and my life, you start to cry on the other end of the phone. Or if it was just a bad week, you might start to cry on the other end of the phone. So that was really hard to call the families and talk to them about, and particularly when people died. We had some patients that we could see we could tell they were going to pass away. And so the hospital would allow some palliative visits, and the family could come up if the patient was going to pass away. And sometimes the family was there for that, and sometimes they weren't. And sometimes people passed away a little bit, not completely unexpectedly, but unexpectedly for when the final event happened.
Right.
And so you have to call and say, they passed away. That was really tough. Because we still had a lot of families that would be in denial, that they would think they're going to be the one that makes it, even though you'd be like, they're not going to make it, no, they're going to make it. I know they're going to make it. And they're not. And that was really tough, especially for younger patients. When patients in their 40s or younger, early 50s passed away, that was really hard for families, because these are people who otherwise might have lived another 20, 30 years. So life cut short. So that was really, really tough to do and to see.
Oh, yeah. What are some of the things that you did to try and take care of yourself with all that? Did you find ways for self-care? Was there...
Not really. No. I don't think I did a very good job.
I'm supposed to have the answer for this.
I don't think I did a very good job of that, I'll be honest. I go to the gym. So I go to the gym 3 times a week, and I went religiously. So it closed down, when things were closed in March of 2020, and then it opened back up when things were allowed to open back up. And it's just, I justified it because I was like, 1, I need it, and 2, it was a small gym. And so it wasn't like the line of 50 treadmills, where everybody's jogging on the treadmill without a mask at the height of a pandemic. It wasn't like that. And often I would be the only person there. But I went, and that was sort of, I knew I was sort of violating what you should do with COVID, going without a mask. And like I said, it's not a big gym. It was often I was the only one there, but still people had been there. There might be somebody else there when I was there. But it was helpful. You know, it was really, really helpful to go and lift weights and just and deal and just not think about, and so I knew I was technically not in compliance with what the CDC or anybody medical was recommending, and I worried about getting COVID that way. Turns out I didn't. I got it at the hospital. But that was probably the one thing that I stuck to, that I just said, I'm just going to take this risk, that I need an outlet.
And I actually think that that's a really important thing to talk about, because like you said, nobody was perfect.
Nobody was perfect.
And so it's this continuous rejuggling of calculations on what
are you willing to accept.
Yeah.
Nobody was perfect. And that, for me, that was something I needed to keep doing, to have some kind of sense of normalcy in my life. And it got tough, I'll be honest, so the last wave that we've had, and I've seen a lot of people just on social media and things go back to their lives, and I've seen a couple of people I know go on cruises, and I'm like, I'm crazy, I wouldn't go on a cruise, definitely not a cruise, travel, okay, I get. But we were having some people I knew went on a cruise, and I just saw it on social media, and we were having one of our more significant waves at the time, this spring, I guess, or this last winter, maybe over the holiday. And I was just like, some people's lives are normal again, and mine's not. And you feel a little like, wait a minute, why isn't my life, and at that point I was really feeling burnt out, really feeling like I'm tired of people crying on the phone. I'm tired of watching people die. And then you go see other people whose lives are kind of back to what was fairly pre-pandemic, I would say. And it's like, wait a minute, you shouldn't be doing that, but okay. But more of, why am I still in the midst of the pandemic watching people die? That's when I started thinking, maybe if this keeps up, I gotta go find. I'm gonna go do a pulmonary clinic and get out of the ICU. That's when I started thinking, I just don't know how much longer I can do this.
Well, and that's the part of the risk equation that people use every day. It's like that, am I vaccinated? Am I boosted? It just keeps going with the next thing. Do I do this? Do I do this? Okay, what is?
Do I need to get a fourth shot now?
Right. So, I mean, I feel like I hear you saying this, but do you have a different sort of equation for that than you think a lot of people that do? Do you think that the math that you do to figure out what is acceptable and what feels safe, is that?
Yeah, I think so. We still haven't started going back out to eat and things like that. I do think it's a little bit different because a lot of people I know never saw anybody and didn't know anybody who passed away. And so they look at things a little bit more flippantly or a little more laissez-faire kind of, whereas seeing a lot of people pass away, and I didn't know anybody personally who passed away from COVID actually, but still seeing, the risk has to be, the benefit has to be a little bit better. There has to be more benefit, I think, than what some people require to sort of break down that barrier a little bit. I do feel at this point, as I mentioned earlier, that my fear of COVID has relaxed a little bit. My concern of getting COVID has relaxed because I had COVID. I had the original strain, so I could still get, but having not gotten super sick and having now I'm fully vaccinated with my booster, I feel like I might get sick, but I'm not going to die. And so that helps. That kind of relaxes my risk quotient a little bit. Where I still mask when I go to large stores and things. But I've been to a restaurant, and sat at a table without my mask. And not many, but I've been to a couple. But I think so, because I see some people just back to normal. Back to whatever, they're vaccinated, so they're like, I'm fine. I'm like, well, you're probably fine, but even fully vaccinated people sometimes get sick, there's that 1%. So, but yeah, I think it's a little bit of a different risk calculator than some people.
Yeah. Can you see a near future where you'll feel like you're just accepting of where we are, like that you'll take off the mask? And
I think so. I think it's getting close. If we can stay or get to a little bit lower level As much as we're not seeing patients in the hospital right now, when I looked at the CDC new guidelines and Oklahoma County was still actually high, which I thought was interesting, because we're not seeing that much in the hospital right now, at least not in the ICU.
Yeah.
I think if we could get to the moderate, Cleveland County actually is. So if we could get in this area of, because you can't, it's hard to separate Cleveland County from Oklahoma County. So if one's high, I think even though Cleveland's moderate, there's still a lot of traffic back and forth between the two.
Yeah.
I think if we could get moderate, I don't know that I would take my mask off for everything, but I would feel a lot more comfortable, I think, than where we're at now, where we're still high.
Yeah.
But I was kind of surprised we were still high just from what we were seeing in the ICU.
Yeah.
We're actually seeing less and less new COVID. We still have some what we call post-COVID now, but we'll have those probably for another month or two.
Yeah.
Because some of the patients just stay and stay and stay.
Actually, that's one of my questions about long COVID or post-COVID.
Yeah.
What are you seeing for that? Because I think that's where we're at now.
It is. Yeah, it's very much. So what we've started calling post-COVID is anybody who's out of the isolation period, and there's no set date of when we really kind of transition from COVID to post-COVID, but usually in the hospital, if they're out of their isolation, so generally about 14 days after their positive test, if they're not having symptoms, we consider them no longer infectious. And so that's when family can come visit, and it opens things up. It's been good for families that we can open that up a little bit more. So families can come visit and see the patient. Sometimes patients are not infectious by the time they get admitted to the ICU, because there is this sort of 2 to 3 week delay sometimes. Some people get more sick immediately, but some patients it takes a little bit longer before they really develop those significant respiratory distress and symptoms. So we consider that kind of a post-COVID is what we're calling it. A little different than long COVID in that the post-COVID is not in isolation anymore. And most of these patients are sort of now long-term vent patients. So there's someone who just can't breathe without a vent. And we see that in other disease processes, but certainly see more of it with COVID.
Yeah.
And so a lot of times they'll go from our hospital to an LTAC facility. That's a long-term acute care facility where they work on long-term vent weaning and just try every day to see if things are a little bit better. Can they breathe without the ventilator? And some patients do. Some patients have gotten there. Many patients have not, even though they're no longer under our care. In talking to some of the community pulmonologists and because all these facilities will have a pulmonologist that goes to them and takes care of the patients there. And in talking to those physicians, a lot of them don't really recover. And then some of them end up coming back for one reason or another to the hospital and don't recover. So it's kind of a long process, and there's just so much that can go wrong. I saw on the news yesterday, some guy went home after being in the hospital for 500 days. And that wasn't in Oklahoma. But you think, how lucky is that? I mean, there's so many things that could have gone wrong in between, that 500
that's
days.
Almost 2 years.
Yeah. So some of these post-COVIDs that we've seen have been between our hospital and the LTAC and maybe other hospitals or back to our hospitals 6 months. We've seen that for sure. And a lot of times they end up passing away from some kind of complication or secondary infection, or just the lungs never recover and the family makes a decision to stop care.
Yeah. So is that what you'd say that you're seeing the most of right now?
Yeah, that's what we're seeing right now. Is sort of that post-COVID, people who still need the ventilator and just can't quite, and probably won't. COVID, we see some patients come in, and it's why one person has it and another person doesn't. It's hard to say, but some patients with COVID have significant lung damage within the first couple of weeks of having COVID. And if you get a CT scan of their lungs, and I haven't seen any studies on pathology of it yet, but if you look at their lungs on CT scan, there's just so much damage to the lungs that it's unlikely that they'll ever be able to breathe without the ventilator. And looking at that, it would surprise me when you see that kind of lung on the CT scan, you're like, they probably won't be able to breathe without the ventilator. And usually those are the patients that just live the rest of their life in an LTAC. You know?
Yeah.
So it's just sad. I mean, it's just so sad because the options are poor. You know, I've spent a lot of time talking to families, and this is true of non-COVID patients too, but certainly COVID patients, like, well, and they're like, well, what do we do now? You know, if they've kind of made it over that initial critical illness, and it's like, well, all your options are bad. I mean, you know, and that's kind of how I start the conversation, because they don't like what you have to say, you know, and like, you can do this or you can do this, but those aren't good. None of them lead to life at home back to where it was before I got sick.
Yeah.
You know, none of it leads to that. Certainly not without a very long route, and most people never can make it there. Probably 99% really can't make it there, especially older patients.
Yeah.
And so I start the conversation with, well, all your options are bad, but let me tell you what they are. And it kind of prefaces it a little bit just to say, you know, I don't have a good option for you. And a lot of times, so I go, they can't go home. No, I mean, you can't. We've had a few people try to manage a mechanical ventilator at home. They do make home vents, but it doesn't work. Yeah. You know, they're for very specific disease processes, like neuromuscular diseases and things like that, not for a bed-bound ICU patient.
Right.
You know, and so they just can't. I've had some people who demand, and they start out, they're going home, I want to go home, and it's like, you're not going to get there.
Yeah.
You know, and home means 24/7 care.
Yeah.
You know, somebody awake, sitting by the bed, you know, it's 24/7 care. So I don't think they realize the burden of, like, you know, it's tough.
So,
I'm sorry, I know you wanted a quiet place to talk.
Oh, no. This is what we got. I mean, I think we can, I'm pretty sure we'll be able to hear everything, so. I think one of the things with this too is, I feel like I know the answer to this, but I want to ask anyway. Do you feel like masking has helped?
Yeah, I do think it's helped. To what extent, it's kind of hard to, you know, because we don't know where we would be if everybody didn't wear a mask. Although, in this state where we might not have seen that much of a difference because a lot of people just didn't mask. And I also think being a rural state helped us to a certain extent, because we just don't see each other as often as, you know, and we're not in contact as much, as particularly with the first strain of COVID, because the exposure was higher than this most recent strain. You had to be exposed to someone a little bit longer usually. It wasn't as infectious. But I think masking does help. You know, I think it helps with any viral respiratory illness. I think if we all would mask during flu season, we'd see less flu. It's just, we're so used to the flu, we don't really think about the flu. We don't really worry about the flu that much. So we don't mask, you know, for things like the flu or RSV or something like that. But I think masking helps probably for anything that's a viral respiratory, you know, and it's what are your risks and what are you willing to do? And, you know, for the flu, I probably won't mask every day during the winter because I'm just, you know, used to it. But I think we will see people, there will be some people who continue to mask. And I think certainly justifiably so. Like, if I was immunocompromised in any way, I would continue to mask, and certainly at least in the winter months. Elderly, when I get older, I might start, you know, because I think it does help those individuals to decrease their exposure and their risk.
Yeah. Which is something you would have never seen 3 years ago for anybody.
Right.
At least in this country.
Right, in this country. But if you look, you know, sort of at some of the Asian, you know, you see a lot more people masking because they've had to deal with SARS, and it's just become part of their culture. I think there will be people in this country who don't ever go back to unmasking. And I think it'll be sort of become an individual choice, you know, as to whether or not you just leave your mask on.
Yeah. Did you have any interesting conversations with like family or friends, or any uncomfortable conversations that you kind of have had to have over time
about masking and just COVID in general?
Yeah.
Not horrible conversations. I mean, some conversations with some friends that are more conservative than me, that didn't want to, that wanted sort of, I think they wanted me to reaffirm that it was what they were saying was, right, and that it really wasn't as bad, or it really wasn't, masks really weren't helpful, that kind of thing. And I just kind of just didn't go down that road. I kind of just diverted it and said, you know what, I had enough of it for 12 hours during the day in the hospital. You can do you. It's not it's not worth it to me. I have some friends that have really pushed on social media and have been more stingent, I guess, about trying to be, a messenger of public health, and have incited debate and all kinds of things, and that's just not me. It's not my personality to go down that road. If someone asks me, I'll tell them, yes, a mask helps. Yes, you need to get vaccinated, but I'm not looking to incite or be inflammatory, or just tell someone who's not going to do it, you need to do it. I'm just not. That's not me.
Yeah.
I'm not. People ask me all the time, like, well, how can you take care of people who do meth? Because we have a lot of meth abusers who end up in the ICU for one reason or another, mostly because they just don't take care of themselves or they get sick. And it's like, well, I kind of have an attitude of live and let live, and I really do believe it, because it's not, they didn't make good choices. I'm not saying they made good choices, but it's not up to me to tell them how to live. I'm just here to sort of pick up the pieces, I guess. I do think the difference between someone like that and someone who refuses to get vaccinated and refuses to wear a mask is that I don't like the argument of, well, it's my body, it's my decision. If you want to go smoke pot or something, okay, fine, that's your body, your decision. But for the mask and for the vaccine, when you say that, you don't understand how it impacts other people. And so I've had a few people that I've had to explain that, by not getting vaccinated, there's more virus in the community. And you may not know the person who gets COVID because there was more virus in the community, or the person whose vaccine just didn't work for them, because they just, were immunocompromised, or, and so I've had a few people have had to, and they just said, oh yeah, went on about their way, because once you put it to them like that, there's really no denying that what the decision you make does impact somebody else. And it's not just, you can say my body, my decision, okay, there is some self-determination, but realize you might be the reason somebody gets COVID. And if you think about it, everybody who got it from somebody. And with the newer strains, people don't really know where they got it. Initially everybody could tell me, that's where I got it. That's where I got it. Right. But with the newer strain, and it's more infectious, most people don't know. Yeah. They've started to get back out socially a little bit, and so they're not, it's that one time because I didn't go anywhere else that, and so they just don't know, and someone could be asymptomatic as well, and so I feel like you actually don't know that you might be impacting somebody else and hurting someone else. Yeah. So I feel like it's a little bit different than just someone who wants to do drugs or have an unhealthy lifestyle or something. Yeah.
Yeah, that's also the hard public debate space with it, right?
Yeah, it's.
So what else is on your list that we didn't talk about?
I think that's pretty much it. I think we really hit on everything. Sorry about the dogs.
Oh, we'll definitely know that they're there. But I think it'll be all right. What have you traveled much since the beginning of this?
Not much, no. We are actually big travelers. We enjoy travel a lot. We went to Greece last August when we were kind of in the lull. I debated whether we should go or not. I really did. But I just wanted to go. And they were still, by that time, there's the federal mandate for masks on a plane, so I felt better about that. And then we were outside a lot. And Greece has a very high vaccination rate. I think it's in the 90th percentile because they depend so much on tourism. So I felt pretty happy going there. We have not traveled anywhere else significantly. And the first in 2020, we go to all the OU games too. I didn't go to any games just because of the pandemic. We thought about going to the OSU game because we had that wave and it was starting to take a downturn, but it started to go back up again. And we decided not to go. And so when we watched it on TV, we were like, because they were only supposed to let like 25,000 people in. There were more than 25. We were like, good thing we didn't go.
I mean, even when you see 25,000 people, 25, yeah, like it.
Right, but even if you let them all sit down in the bottom part of the state, if you let them cluster together, it doesn't matter that you've limited, So we were pretty happy when we saw it on TV. We were like, yeah, we're glad we didn't go.
Yeah.
That would have been too big of a risk, I think, at that point, because there was no vaccine or anything like that, you know.
Right.
Yeah. So once we were vaccinated, we said, and so we did go to Greece. And we enjoyed that. That was nice. We're going to go to Italy this July. So I'm crossing my fingers. There's no new strain or anything.
Yeah.
But I think we're just at the point, like a lot of other people are always like, we want to get back to our lives. We really want to there are some things that I'm like, okay, if we don't ever go out to dinner as much as we did before the pandemic, that's okay. That's actually better for us. I'm fine with that. And I don't miss that. I don't really, and just by convenience, we ate out a lot. It wasn't, but by convenience. And we don't have to change that back. I'd be okay. But the things that really are important, and I think I'm like everybody else, the things that are really important that you really enjoy doing, really want to start doing again. I think everybody does. There's just this fatigue of staying home and not being social. And there's a lot of fatigue of just being cooped up.
Oh my goodness, yes. Are there things in your job that you think have been changed by this that won't go back to pre-COVID?
I wonder if the hospital will ever go without masks again. I don't know why the hospital would. I mean, a hospital is a place where people are sick, so it
like
kind of makes sense.
Public people coming in as well. Yeah.
It wouldn't surprise me, if the hospital doesn't ever go without being masked, and people are sick there, so you probably should wear a mask. It makes sense. I think it'll be interesting to see how the relationship with families goes moving forward. Because one thing we did see with COVID to a certain extent, and I haven't seen it as much lately, but one thing we did see with COVID, as families became much more demanding of what they wanted, that spilled over into some of the other diseases that we commonly see. That, I remember we admitted somebody who had a large intracranial hemorrhage, right, a huge head bleed, that was not survivable. And I remember talking to the family in the ER, and they said, I said, there's not really anything surgically we can do. There's really and they're like, well, we want a neurosurgeon to take the blood out, to, basically open it up and,
release the pressure,
relieve the pressure and take the blood out. And I was like, well, that doesn't help because you've had this lack of oxygen to the brain by the lack of blood flow from the bleed. So that doesn't really help. That's not going to be a benefit. And that surgery is a very high risk surgery. And so when surgeries don't have a big benefit, but they're very high risk, we don't do them. And the neurosurgeon had come by and said, no surgical options. And the family just looked at me and said, well, but we're requesting it. Well, I'm sorry, and I'm just like, well, I don't know what to tell you. If the risk is too great and the benefit is too small, we're just not going to do it. And so we've had conversations with some of the physicians at the hospital of like, well, where do we draw the line? Like if somebody wants their loved one to get some vitamin C supplementation, do I care? Not really. It's probably not going to benefit, but it's not harmful, right? Mm-hmm. And we're starting to have these conversations as physicians, because then some people are like, no, don't do it, because, then they're going to want something else. And a lot of us are taking an attitude of, well, you can't do things just because you're tired of the mask, because it's a battle for some families. It's an everyday battle, and you can't do things that you wouldn't do otherwise, that aren't standard of care, that aren't your standard practice, because everything has a risk, and if something bad happened, you can't sit there and say, well, I did it because they wanted to, even though I knew it wasn't going to be a benefit. But you're the medical person, you should know, and so we've taken an attitude like you have to stand your ground, and you have to say, if it's not going to have a significant benefit and the benefit isn't better than the risk, sorry, we can talk about why we're not going to do it, but we're not going to do it. And then that's tough, but we still see, not to the extent as like in the height of COVID, not to that extent, but we still have families coming in with non-COVID things that they're like, but we want that.
Yeah.
And I'm like, well, medicine doesn't work that way. Unfortunately, I'm sorry.
And that's something you didn't see a lot of before COVID.
Not really. Every once in a while, but not as much as we do now. Mm-hmm. And I think it's good for families to be informed. And like I said, we definitely see more informed families. And so for some families that are, I don't want to say more educated, but more reasonable, I guess would be a better, that's very helpful because you can have a little bit higher conversation about what's going on and they have a better understanding. But for other families have taken it people have taken it in a different direction of, well, now that I know more, I have more say. And people always have some say in their care and get to choose their options and can choose care they don't want, but it still medically has to make sense, and I think that's where it comes in. It's like, well, you can make some choices as to whether you want chemotherapy, you don't want chemotherapy, you want radiation therapy, you want to be intubated, you want to be on a vent, you want cardiopulmonary resuscitation. You do get to make some choices, but medically they all have to make sense. You can't tell me, well, I want a big surgery when when it has no benefit, and that's been tough.
Yeah, I
don't think that's going to go away. Hopefully, it's not as much as what we saw in COVID, but I don't think it's going to go away. I think it'll still stay. Mm-hmm. And there's a lot of distrust. There's a lot of distrust of the medical community where we get other families saying, again, you're just doing this because for XYZ reason, because so we definitely see distrust that we didn't see before. Mm-hmm. So hopefully that'll get better. We'll see.
Do you think that is greater in urban areas or rural areas or about the same? I mean, there's no reason you would know that answer, but just a sense.
Yeah. I would say it's probably about the same. And it's surprising. Like sometimes we'll admit somebody from maybe a rural area and I think, this family's going to be difficult. And they're perfectly normal, easy to get along, very reasonable people. And so it's hard to predict, Yeah. And whereas we'll admit somebody whose family's, more educated and you think, oh, okay, and they're completely unreasonable. So it's hard to predict who's who. But I think it's about the same. Yeah. I think there's this idea in our healthcare system, it's a little bit different than other healthcare systems. There's this idea that I should get everything and anything that could possibly be done. And with COVID, we saw shortages that we never had to deal with before. We saw shortages of drugs. A lot of them didn't work, but we saw shortages, and so you'd be talking to families and they'd say, well, I want them to get the monoclonal antibodies after those got approved, and we couldn't get them. And we wouldn't give them to inpatients because they were only approved for outpatients, and they probably would have had some benefit to some inpatients, but not really sick ICU patients at that point. I don't think that. But there's this attitude of, we shouldn't have to deal with that in the U.S. And patients' families would get very upset if we didn't have this drug or we didn't have availability for this thing. And I think other cultures deal with that a little bit differently. I don't think they have this sense of entitlement that we do, which is interesting to me because we don't have universal health care. So we have this huge entitlement, but we don't have universal health care. It's interesting, it's kind of a contradiction a little bit.
To a certain degree, or we pay for it. We should get access to anything we want, right? Like
right. Right. Yeah. So it's kind of an interesting, but we see people who just have this distrust, like I'm holding back medication for my family, or some, and so I think the shortages that we faced kind of brought some of that on, where we just couldn't offer a drug here or there.
Yeah.
Because we didn't have it.
Or toilet paper.
Right. Or toilet paper.
Yeah.
It's funny, I always liked healthcare and thought health was so interesting because everything revolves around it. And you see that in the pandemic, supply chain is messed up. People can't staff restaurants. Everything revolves around health. Mm-hmm. If you don't have a healthy society or healthy people, you're stuck and you can't get near as much done. Economically, it's a huge impact. And I never thought about it so truthfully as I do now. I was like, well, I always kind of thought that, but whoa, that was really right. Everything is impacted by it.
Yeah. Yeah. Well, we definitely have evidence of that.
Yeah.
More than we ever needed.
More than we ever wanted to know.
Oh my gosh. I think that's what I wanted to talk about. I'm trying to think if I had any other questions that we didn't just talk about.
I'm trying to think if there's anything other aspects that.
I do have one more question. Because part of the reason why we're doing this is, not necessarily for people that want to listen to it tomorrow, but thinking forward, 10, 20, even 50 years from now. Kind of like people are looking back at the Spanish, right, the 1919 influenza and going, what can we learn from how people, which apparently it's a lot about how people communicate.
Right.
But what would you think is important from this, that people 50 years in the future, reflectively looking at this, might be important for them to know, or to things that were surprising, or things that you think, gosh, it'd be great for you. Information, right?
Right. I think one of the things that I didn't expect beforehand, and it's maybe because I'm not an epidemiologist or anything by trade, but the waves that we saw. I think you'll see that in anything, they probably don't need me telling them that to figure it out. But I wasn't expecting just wave after wave after wave, but I think they saw that somewhat in the Spanish flu to a certain extent. People weren't as mobile, so maybe not quite, as quickly as we would see them.
Yeah.
I think so much of it depends on how we look at our society. We have such individualism at the heart of it, and it's me first. That I think if someone sees a pandemic coming, they should try to have a campaign of a global society and a global, we're all in this together kind of, if there's any way to promote that early on, a little bit better. Because I don't know how you do that, but that's where we really saw, so much, I think, so many problems, because it was very much an individual thing. And really, we were all in it together from the beginning, and we might have done a little better had we looked at it as a more we're all in it together kind of attitude, not only from the standpoint of wearing a mask and getting vaccinated and those kind of public health things that you can do, but also in a standpoint of how we take care of our sick. I don't think, and some states might have done it better. I haven't seen any kind of reporting, but I don't think we did a very good job of coordinating our care. And clearly, you do better if it's coordinated. I think we would have done better. I think we had non-COVID deaths because our care was so poorly coordinated, and increased COVID deaths as well.
Yeah.
That's just, so I think, I don't know how you do that, how you convince people, we didn't do a good job of that this time. So I don't know how you convince people that, what happens to your neighbor or the guy down the street or the person the next town over, it does impact you.
Yeah.
It does impact you because if for no other reason than like what we talked about with the economy, that may be the person you need, the plumber that you need in a month or two, or the teacher that's going to educate your children. We're all so interdependent, but yet we don't want to feel like we are. We want to feel like it's me, especially in Oklahoma. It's me. I don't need any help. I don't need anybody. And it's like we all need somebody.
Yeah.
Our dog.
Your dog needs you.
Our dog, something to kind of lean on and help.
Oh my gosh. I think that's true too. All right. Anything else?
I can't think of anything else. I'm so sorry about the dogs. Oh,
It's understandable.
so much for a quiet place.
It's understandable. It's totally. All right. Well, then I'm going to go ahead and turn everything off on this end.